Good evening, everybody. Welcome to the third edition of the Geriatric Oncology Virtual Tumor Board. And I think the way that the cases have been presented and discussed is clear indication how vital this is. If you look at the statistics and the projections, even if you look at the oldest old, that is above the age of 80 years, the incidence of cancer is going to increase um, to a tune of more than 2 lakh new patients every year in India. And therefore, I think the earlier we are ready for geriatric oncology, the better it is. And therefore, Prem and I have been doing this program, virtual tumor boards, as well as webinars under AGOS since several months. And now I hand over to Prem to carry over the proceedings for today's tumor board discussion. Prem and then Tongaonkar are going to be the presenters, and they will introduce the panelists as well. So, Prem, over to you.
Thank you, sir. Of course, under your leadership and with all the initial members of AGOS, it has been a good journey wherein we have been able to create webinars. And of course, I think the tumor board format has been really, a good discussion. So, of course, I also have with me Dr. Arnav, who is a medical oncologist with Mumbai Oncocare Center. And I would just introduce the geriatricians and, of course, would request Dr. Arnav to introduce the medical oncologist as well. So I have with me, of course, Dr. Nabil. Dr. Nabil is a geriatrician from Sri Ramachandra Hospital, Chennai. Welcome, Nabil, and thanks for coming on. Dr. Nadeem, welcome. He's from Aster, Calicut. Kerala has been sort of recruiting a lot of new geriatricians, and Dr. Nadeem is one of them leading the way. So welcome, Nadeem. And of course, Dr. Pramod. Dr. Pramod, I have had the privilege of even teaching to an extent. He was a resident, and now he has grown up to almost being an associate professor, almost in AIMS New Delhi. So welcome, Pramod, and thanks for coming on. Dr. Arnav, if you could just introduce the medical oncologist.
Sure. Good evening. So we have with us Dr. Kunal Jobanputra, who is a medical oncologist with Mumbai Oncocare Center, Mumbai. We have Dr. Kasturi Baruah, who is a medical oncologist with Mumbai Oncocare Center. And we have Dr. Dale Rodrigues, who is a surgical oncologist on our panel today. Sir is also from Mumbai.
Okay, so thank you, Dr. Arnav. Okay, so I would now request Dr. Arnav to start with the case presentation. And then, of course, I would also be involved in asking questions. So thank you, Dr. Arnav. You can go ahead.
Sure, I'll start sharing my screen. Is my screen visible?
Yes.
Yes, we can see.
Sure. So we start with the first case. The patient, Mrs. S, is a 74-year-old lady diagnosed with invasive ductal carcinoma of the left breast, ER/PR positive, HER2 negative, stage 3B, locally advanced with axillary lymph node involvement. She presented with a palpable left breast lump for 3 months associated with nipple retraction. Her medical background and comorbidities: she is a hypertensive since 20 years on amlodipine and losartan. She is a type 2 diabetic since 15 years with a suboptimal glycemic control, high HbA1c 8.2. She has chronic kidney disease stage 3A with an estimated GFR of 45 ml per minute, ischemic heart disease, post angioplasty on dual antiplatelets, beta blockers, and a statin. She has mobility restriction due to osteoarthritis, and there is a mild cognitive impairment. So on her, we'll now come to the comprehensive geriatric assessment. Dr. Prem, if you want to join from here.
Yeah. So before I go into the CGA findings, I would just want to first let me ask maybe Dr. Nabil first. So you saw the CA part. and you also saw the fact that he has got so many comorbidities. So do you, without doing the CG, I mean, of course, without it presented to you, do you think how fit his older adult would be to for any kind of intervention, medical oncology? I mean, through oncologically. What is your take?
Yes, sir. Good evening. Thank you for having me here,
Yeah.
sir. So, as a geriatrician, we should look beyond the tumor. As we look at the age of the patient is 74 years, but the chronological age does not always match with the biological age of the patient. So, for a patient with the same chronological age, will have different biological ages, and the physiological reserve, it dramatically varies between different people. That depends on the number of comorbidities and the number of medications that people are taking, and that depends on the nutritional status of the patient, and that also depends on the functional status of the patient. So, looking at our patient, in a nutshell, she's a 74-year-old female with a stage 3, that is locally advanced breast CA, ERPR positive with HER2 negative cancer. So here, before coming to this comprehensive geriatric assessment, so let's try to medically optimize this patient. So before any oncological interventions, so that is first we try to correct the reversible issues, that we call it as a prehabilitation actually. So that is first one. Prehabilitation means whether any nutritional rehabilitation, rationalizing polypharmacy,
Yeah,
and
I totally agree with you. I think, I mean, offset, I would say maybe with multiple comorbidities, we would still want to do the CGA and then go ahead, which of course we have done. So, I mean, I'll just involve Nadeem now with the interpretation of the CGA. Now, as far as the functional status is concerned, you can see that TUG is 18. There is obviously a high fall risk. Then cognition, there is mild cognitive impairment, maybe mild depression also. Nutritional status is also albumin is 3.2 with borderline MNA, she's at risk. BMI is also 21. Charleston's Comorbidity Index is 7, 8 medications. You saw, I mean, you don't need to do a Charleston's Comorbidity Index. There were so many comorbidities, to be very frank. And potential drug-to-drug interaction and social support, of course, good support socially, but bad financially. So, in a nutshell, if you have to see the CGA, the most important part is your initial interpretation, and then, of course, we'll talk about intervention. Yeah.
Yeah. So, thank you, Prem. When coming to the comprehensive geriatric assessment, as maybe told, we geriatricians see the patients in a holistic way. So, coming to comprehensive geriatric assessment, it gives beyond the comorbidities and the age as a normal physician. So this geriatric assessment helps us to look at the beyond the data, clinical data. So coming to functional status here, the TUG is, as you all might think, oncologists will be at least heard of once in a while. They might have heard of this TUG. Typed up and go test, which will help you. It's the most simplest and commonest practiced tool that will help you in assessing the fall risk. So that means at least it should be less than 12 that the patient is having a normal, is able to get up from the chair, walk in a normal place, turn around without any difficulty. He's coming back and sitting into the chair. All these are assessed so that he can do. I believe that the time is not important for that test. It's all the how the patient can affect. It's a visual impression of an experienced doctor, which will help you more in that test. So looking at the drug test, the time itself is showing that drug is so much long and there's very high fall risk. And most of the, even though most of the ADLs are independent, the IADLs are dependent. Maybe he's not able to.
So as a geriatrician, would you want to, what would be your verdict? I mean, let me get in Pramod now. What would be your verdict on this before the oncologist is going to take a decision? Are you going to encourage them okay, fine, whatever plan you are going to do is fine, or do you feel that there is certain things we need to do before we actually, I mean, even think of any kind of therapy? Yeah, Pramod.
Thank you, Dr. Prem, and good evening to all the panelists. I think I would interpret this CGA as the patient as intermediate risk, and these are the patient who would benefit most from an interventions point of view. These are the patient who need CGA and who would benefit more from domain specific interventions. So the oncologist assessment and plan could be made. Along with that, we could start intervention for these patients. For example, obviously the comorbidities are there. We would optimize the comorbidities, his CAD status, another blood sugar control, renal function will see. Then his symptom burden will need to see is there any history of angina currently, and dyspnea. Then his medications we need to optimize, and then the function status is said that IED is dependent. So is it because because of his osteoarthritis, or is it because of his dyspnea or angina? So we need to see what are the factors which are limiting his functional ability, because if the patient goes for any oncological intervention, so these limitations can be critical in the post intervention or post during the rehabilitation period. So we need to optimize these. Similarly, the mood, cognition, these are also borderline. They are not completely impaired, but they're not completely normal as well. So here we could obviously start with non-pharmacological management first, and then see if there's a more detailed assessment could be done, and see if pharmacological or other interventions are needed in these patients. Similarly, nutritional rehabilitation can be done, and as I said, comorbidities and medications could be optimized. So I think this is a very good candidate for geriatric interventions, and it could be done alongside the oncology assessment and planning.
I want to just raise a point here. So I think like Dr. Pramod said, so when we are talking about prehabilitation, how much time window do you feel you would like to allot to this patient for prehabilitation? Because do we end up delaying the treatment till the patient is optimized, or do you think both things can proceed simultaneously?
So we usually would not like to delay the treatment, but we need to see if the interventions are invasive. We are talking about a major surgery or chemotherapy, multi-drug chemotherapy. Then and the patient is not fit, we'll see the risk benefit ratio, and if the patient seems having more risk from the intervention, we would certainly wait for some time, and we would like to optimize. But in this patient, I think major would be his cardiac assessment. If his cardiac assessment is good, we could and so breast cancer, if he could be a candidate for hormonal therapy, we could proceed with the the oncology intervention along with continuing our other intervention, geriatric intervention. So one of the point that we need to assess would be the cardiac assessment, cardiac risk.
Yes,
Just
sir. Arnav, before you sort of ask the oncologist, I just have one question to the oncologist in the panel. Is that before the before the comprehensive geriatric assessment was done, were you okay to just go ahead in spite of this person having so many comorbidities, or or would you be a bit jittery in thinking, no, let me just wait, optimize more things? So I mean, is that a thought process which you would have? I mean, Arnav, you can also answer, and then maybe you can take the discussion forward. Yeah.
Sure. So I think I agree that in terms of comorbidities, it is important to have everything sorted out. Particularly if there is a cardiac history, I want to know what ejection fraction is going to be there. If I'm considering any chemotherapy involving a cardiotoxic drug, doxorubicin might be a consideration. I want to know the baseline ejection fraction. Those things should be optimized. At the same time, a routine geriatric assessment, it adds a layer of objectivity. So rather than saying that the patient is just old or frail, we have an objective criteria basis which we can take a subsequent decision. So I pass on the question to the panel. Would you like to add anything from their side, medical oncologists? Dr. Kunal, Dr. Kasturi, if you can join us here.
I feel that yes, we should go ahead with a comprehensive geriatric assessment in this case. But however, I feel that baseline we should also get an idea about what is the life expectancy. So as we can see, so many multiple comorbidities are there. So after, if we feel that the patient has a substantial life expectancy, and after this assessment, I think then we would like to take a call on what best possible treatment we can offer.
Dr. Dale, so this is a locally advanced case, so probably for neoadjuvant treatment, but supposing she was a lady with an operable breast cancer and this list of comorbidities, would you be comfortable to operate immediately or would you like to take some time to optimize?
Of course, hi, Dr. Arnav. Thanks for having me. We should, of course, we should optimize her, but we don't have much time in optimization. If you say that she's not optimized, we can't wait for a go ahead. We will have to do it at certain point of time.
Okay, so we want to optimize, but not at the same time, not compromise the oncological outcomes by delaying too much. I think that would
Correct.
be consensus from everybody. Shall we proceed with the next slide? Dr. Prem.
Sure.
So now we have the CARG score, which is a chemotherapy risk assessment. It is the Cancer and Aging Research Group toxicity score, and it basically estimates the risk of grade 3 and higher toxicity in older adults. So there are many parameters. So let me put the question to Dr. Kunal. Dr. Kunal, are you logged in? How frequently are you using the CARG score for your baseline assessment when you're assessing geriatric patients? Dr. Kunal, Dr. Kasturi.
So I think, hi, Dr. So CARG is one of the routinely used scores assessment technique to assess whether what is the anticipated risk of chemotherapy-related toxicities according to number of agents and also the routinely commonly employed dose reduction. So it gives a good, fair idea.
Absolutely. So frequently when we're working in geriatric clinics, we run the CARG model using various permutation combinations, whether we are using a polychemotherapy full dose or a polychemotherapy reduced dose, or are we using a monochemotherapy? And sometimes that helps in our judgment, whether the patient is likely to tolerate a polychemotherapy at a full dose or a reduced dose, or should we give a single agent treatment? So it is something that is pretty valuable. So I just read out the CARG assessment for this patient. So the age more than 72 years is the first variable. So yes, it is 74 for this patient. The cancer type is breast cancer. The planned chemotherapy for this patient was actually endocrine therapy because she's hormone positive. Her hemoglobin was borderline 11.2. Creatinine clearance was not less than 34. No hearing impairment. One important criterion is the risk of more than one fall in the last 6 months. So no falls, but she has a high fall risk. She is limited in walking 1 block because she needs a walking stick. Her activities of daily life are limited. She is independent. Pardon me, she is dependent. She has a social activity limitation with reduced social engagement, and she is already on polypharmacy. So the interpretation would be high risk of chemotherapy related toxicity. So Dr. Kasturi, supposing this patient was not hormone positive, now you had to plan neoadjuvant treatment for her. Would you prefer starting a regimen like EC for her, epirubicin cyclophosphamide, or would you like to start with a lower dose of weekly paclitaxel, something like that?
Yes, honestly, looking at the CARG assessment, I would not be very comfortable with the anthracycline-based therapy regimen. I would rather start with a weekly chemotherapy and with a dose escalation. I'll start with a baseline dose at around maybe little dose in less dose intense and dose dense, and followed by increasing the density and the intensity based upon the tolerability. So would not rather start with anthracycline-based therapy for this particular patient.
Agreed. So how frequently are you using the CARG scores to make your decisions, Dr. Kasturi?
So this is based majorly on the clinical assessment because we don't have a, yeah. So if I personally feel the patient is rather frail, then we go ahead with the assessment with the tool, G8 tool. And then based on the GA tool, we go ahead with, if the patient is fit enough, then we go ahead with the CARG scoring.
Yes, so I think Dr. Kasturi has raised a very valid point also here. Many times we make this judgment on a clinical assessment rather than a formal geriatric assessment. And practically, it's not always possible to do a comprehensive geriatric assessment, though we should be doing it, we should be spending the time. But in settings like government hospitals and high volume centers, it's not always possible. So still out of these things, probably if you ask me practically as a medical oncologist, CARG is something that adds a lot of value and it doesn't require much time. The calculators are available and it adds a parameter of objectivity to our clinical decision making.
Yes, yes.
Any inputs from Dr. Prem from the geriatrician point of view?
No, we can move on.
So as we discussed, this patient is hormone positive, strongly positive, HER2 negative, likely to benefit from hormonal therapy. It's a locally advanced disease, so not upfront surgery. Probably she requires some form of neoadjuvant treatment. And the concerns. So CKD, cardiac disease, limit the chemotherapy medicines as we discussed. So Dr. Dale, this patient has come to you in OPD. We have the parameters in front of us. How would you like to proceed?
Yes, if it's ERPR positive and a locally advanced tumor, definitely some form of neoadjuvant therapy should be given. I agree with you.
Agreed, sir. So you will require some form of downstaging before we proceed with the treatment.
Right. There's no point in doing a half-hearted surgery and having positive margins.
Absolutely. So our medical oncologists on the panel, how have your outcomes been with hormone treatment alone in this population? Would you be comfortable to recommend that as the neoadjuvant treatment?
Definitely.
Sure. So as we have discussed most of these points already, these were our multidisciplinary team discussion points for this patient. The surgical feasibility, there is a high perioperative cardiac risk. We need a cardiology and anesthesia fitness. Systemic treatment options, endocrine therapy is favored. Chemotherapy less favored due to comorbidities. Radiation therapy may be shorter course if indicated later. We need the supportive care management. So optimizing the sugar control, CKD management, physiotherapy, nutrition, and her depression. And we want to do shared decision making. We want to involve the patient and their caregiver. So sometimes it is important for us to understand what is the patient's goal of care. What do they want out of the treatment? We are always disease oriented, but we also need to be patient oriented and understand what it is that the patient wants. Some people, even if there is a potential for cure, but they may be undergoing a toxic treatment, they may opt only for a less intense treatment that may not cure the disease but will maintain their quality of life. So the preliminary recommendations for this patient are to optimize the comorbidities before any cancer-directed therapy. We can start with endocrine therapy while assessing fitness for surgery. Consider the surgery only if cardiac clearance is obtained. And if surgery is not feasible, then endocrine therapy with maybe some palliative radiotherapy and regular geriatrician follow-up and supportive interventions. So I leave that open to the panel. Any changes or any additions to this? Panelists, anybody has anything to add here?
Dr. Arnav,
Yes.
I think palliative radiotherapy is not an option at all.
Yeah, even if that probably has been added that in case there is any function or progression later.
Yeah.
So that is why. So I think we'll remove that from our recommendations.
Yeah, even if
Yeah,
there
so
is
if it is required.
still, because it would further not allow the wound to heal.
Absolutely, absolutely. So thank you for that input, sir. With that, we'll move to the next case. Pardon, we have one slide too. So these are the geriatric
So
interventions. Dr.
so just involving the geriatricians in the panel. So these are the optimization which we would obviously want to do as geriatricians already maintained, of course. So for us in this particular case, which we obviously saw, so what would be the most important thing as a geriatrician? I mean, Dr. Pramod can take that maybe. You're on mute.
Yeah, so medical optimization is very important. I think, as I said, cardiac risk was a major factor here, and diabetic control as well. We would like to assess the cardiac risk, and RCRI score can be used, taking into account his renal function, diabetic status, and cardiac and status, or any other heart failure or severe history. So this could be done. I think also the supportive care is very important. His plan for endocrine therapy, so bone health is very important. He is already osteoarthritic, risk of fall. So any fracture while during his treatment would be devastating, affecting his outcome. So proper assessment of bone health, DEXA scan could be done, and if required, treatment adjuvant therapy uh, with the calcium vitamin D could be started alongside, and if required then we can move to additional therapy, and plus along with physiotherapy, so resistant training, guided resistant training, gait and mobility training, and if required any walking aid or
Sure.
any sort of assistive
Already
device.
using walking aid actually. So maybe
Yeah.
if it worsens, then we might have to. Okay,
So-
just let me involve Dr. Nabil in now. Dr. Nabil, are you concerned about the cognitive issue? What would you want to do about the cognitive issue? I mean, already the MMSE was a bit down, but depression is also positive. So do you think it is pseudo dementia, or do you think it was cognitive impairment with depression? What? Because ultimately, if we don't optimize these individual things, then the required result might not be there for the oncologist, as far as my experience goes. Yeah.
Yes, sir. First of all, we should see whether this is a real dementia or pseudo dementia because of depression. So we can start with a low dose antidepressant and see whether the patient can improve in their cognition. And one more problem with the cognitive impairment is the decision making and consent giving is of utmost important. The patient wants to go for chemotherapy, and one more important thing is adherence to chemotherapy. The patient is cognitively impaired, whether they can come for regular follow-up. So all these things can be affected. So one is about the decision making, then consent, adherence, safety. So all these things can be affected if the patient's cognitive impairment is there. So we should include the patient, the caretaker always with the patient. So for a shared decision making is important.
Okay, so overall, of course, we are seeing that we will be able to provide therapy, hormonal. We are not going to be able to do surgery. Yeah, chemotherapy looks dicey. Dr. Nadeem, would you want to broach the topic of a living will? It's an important topic. Would you want to broach it? If you broach it, how would you want to do it? When would you want to do it? Because the person is already under quite a bit of stress because of the fact that there is an oncological situation. If you start talking about living will, then maybe she might think that it's basically something which is, I mean, my life is going to go. So how would you broach it? If not now, when would you want to do it? It's a difficult question, but it comes very commonly in our practice. So.
It's very common and it's also a difficult situation that we encounter in the daily practice. So actually, it should be it is a very sensitive area. So it should be the patient party, the bystanders should be not completely involved. You have to be with the patient. The patient has to be given the prime importance. And with all the limitation with the cognition, depressive part, all has to be considered. And with all the cognitive and psychological support that we provide to the patient, along with that, in between, we have to give the option and we have to give all the possible support for providing the living will. And say that that has to be done. That has to be done for every patient. Not only it's not a part of end of life care, and all these
Exactly.
concept has to be conveyed properly, and that has to be done along with the cognitive and psychotherapy.
Exactly. Okay, Pramod, you want to say something, but quickly before we go to the next.
Yes, one more thing regarding cognitive and psychological health. Patient may not need pharmacological treatment. Non-pharmacological treatment may be good for him at this stage. And there's also a risk of delirium, which we need to assess. And so hence intervention in this regard is important to do a more detailed assessment of cognition and depression in this patient, and always consider the risk of delirium before any intervention, before and after any intervention.
Okay. Thank
Can
you.
can I make a
Yes,
point?
sir. Yes, sir. I was going to ask you only, sir. Any questions, and then we can move to the next. Yeah.
So one of the panelists talked about life expectancy and in the decision making. So I think non-cancer life expectancy is very important to decide what is the goal of the cancer therapy. But at the same time, we must understand the concept of conditional survival. So if at my birth, my life expectancy was 65, and now I've lived up to the age of 60 years, doesn't mean that my life expectancy remains the same. Now it has actually increased to 72 or 75 years. So life expectancy is also to be calculated based on the current age of the person. And if a geriatric person has lived so long, biologically the protoplasm is of a superior quality, and therefore the life expectancy is more. So that was the first point. And the other point was Arnav mentioned about what is the patient's expectation out of treatment. And I think that is a very, very crucial. And Prem, when you ask the question of living will, I think the dialogue can be started by deciding or discussing and understanding what is the patient's expectation. And then we can
Yes.
gradually move on to the living will. So I thought I would say these 2 points. Thank you.
Absolutely, sir. Absolutely. You hit the nail on the head. Yeah. So, Dr. Arnav, you can proceed with the second case.
Sure. So the second patient is a 78-year-old gentleman, Mr. R, diagnosed with adenocarcinoma of the sigmoid colon, stage 3C, that is T4A N2 non-metastatic. He presented with altered bowel habits, anemia, and intermittent rectal bleeding since 4 months. The recent event was a subacute intestinal obstruction managed conservatively with Rice tube decompression and fluids. So again, he has a lot of comorbidities. He is a hypertensive 25 years, since 25 years on calcium channel blockers and ACE inhibitors. A known diabetic since 20 years with diabetic nephropathy. A GFR of only 25 ml per minute. He has a COPD with frequent exacerbations on home nebulization. He has congestive cardiac failure, NYHA class 2, class 3, with an EF of only 38%. Mild cognitive impairment, MMSE 25/30. He has an anemia, hemoglobin of only 8.9, anemia of chronic disease, and an iron deficiency anemia due to the rectal bleeding. So, Dr. Prem?
Yeah. So, I mean, yeah, at this particular junction, just want to involve maybe Dr. Kasturi here. So, as an oncologist, where do you see this particular gentleman is going as far as treatment part is concerned, without the geriatric assessment being provided to you?
So I feel it's going to be quite a bit of a challenge with all these comorbidities. And really, actually, it is a medical, I mean, it will be very difficult for me to medically manage him. So this actually, without even a comprehensive assessment, I can feel that it's going to be a challenging situation with all these comorbidities, and that too, and the fag end of the comorbidities, what I feel.
Okay.
Just
Okay.
Could I just add a question to Dr. Kasturi
Sure.
here, or to Dr. Kunal, Dr. Dale, if you want to join? In general, if it was just stage 3 CA colon, even at this age, if the patient is fit for surgery, what is the kind of outcome that we are expecting? So just to give a context to this discussion, what is the kind of survival that we are expecting?
Yeah, Dr. Dale or Dr. Kunal.
Yeah. So this patient is having rectal bleeding since last 4 months, and his hemoglobin is low. He's in subacute obstruction. Ideally, he should have first optimization quickly with his diabetic control, and a stoma needs to be done for him immediately. So that would settle down his eating and passing motions, so that everything else will go further down the line for him.
Absolutely. So if we were able to treat this patient, I mean, not this particular patient, but a stage 3 CA colon patient, we are still expecting outcomes above 60%, if I'm not wrong. So just to add a
Yeah.
context that even though there are a lot of issues here, still it may be worthwhile to treat this patient. That is what I was trying to bring across.
Sure. Yeah.
Yeah, definitely.
Yeah. Dr. Arnav, you can just change the slide. Okay. So yeah, Dr. Nadeem first, and then maybe followed by Dr. Nabil and Dr. Pramod. So how do you interpret the CGF?
Yeah. In this patient, CJ is very important because even though despite of all these comorbidities, function status, knowing the function status is very important because even though despite of these comorbidities, the patient's function status is very good, function status and cognitive status is very good. Then there is a hope still considering all these comorbidities, patient may benefit from surgery and active interventions here. But in this patient, ADLs are partially dependent, IADLs are dependent. Is very much prolonged. There is very high fall risk. Cognition MMS is only 25/30. GDS is 8. It's mild to moderate depression. And nutritional status, EMI is very low. And because again, long side, any nutrition assessment you can see is again patient is malnutrition. There is a recent weight loss. The patient is having multiple comorbidities. Charleston's index is 9. There is more than 10, nearly 10 medication. So there is very high risk. And the polypharmacy is significant. And patients living with son, daughter-in-law, and there's a good caregiver support and patients stable and use that part is good. And all other modalities of geriatric assessments. The lower side.
Yeah. Yeah, Dr. Nadeem. So yeah, fair enough. Dr. Nabil, I would want to ask you specifically, would you want to prioritize? I mean, as a geriatrician, we always have to prioritize. So would you want to prioritize one finding over the other? What is the most, would you want to say that this particular thing would be more important in this particular person, which we want to address first, which we do a lot as geriatricians, as compared to something else which we can handle later, because ultimately this is a glaring thing which we are finding.
I just want to prioritize two things. The functional status, because the chemotherapy intolerant, the functional status is a strong predictor of chemotherapy intolerance and the post-operative complications. So after starting chemotherapy, the patient's functional status may decline so much beyond this level. So first of all, we should optimize the functional status of the patient. And second, coming to the nutritional status, so if you look at the BMI,
Exactly.
it
I
is
wanted to
below the
highlight
normal
the
level, that is
nutrition part,
19.5.
because I think that would be the biggest
Yes.
challenge here. Already having a bad
Yes, sir,
nutrition,
yes.
then as Dr. Dale also mentioned,
Yes.
I mean,
That will increase the that will add on to the chemotherapy induced fatigue or cancer induced fatigue, and this will delay the wound healing also, like poor nutritional status. So whatever if the patient is going to go for any palliative surgery also, this nutritional status will delay the wound healing, and it will increase the fatigue also.
Okay. Dr. Pramod, do you want to delve into the cognition and depression at all, or would you want to just first optimize the person, make the person fit for the intervention and deal with that later? You're on mute.
The patient has multiple comorbidities. We need to first optimize his heart failure, COPD with frequent exacerbations. So these two need to be optimized, and maybe with improvement in his dyspnea and this exercise capacity, maybe his functional status will improve. Maybe his mood may also improve with this. So as I said, for such mild cognitive impairment or borderline GDS, we won't like to go for pharmacological treatment. We'll go for counseling and non-pharmacological treatment, cognitive therapy first, and optimize his comorbidities. Even with his anemia, his dyspnea may be more. We are not again sure whether his ADLs are because of dyspnea or because of any other reason. So we really need to optimize his medical conditions, his heart failure and COPD. and CKD is also there. So any fluid overload is there, we need to see, and maybe optimizing these medical condition may have a benefit on his cognition mood also. So that is the way I would go.
Okay, as Dr. Dale already mentioned, as a surgical oncologist, I am telling you that no, you have to optimize quickly because I need to get the nutrition on point. So I have to create the stoma and I have to make sure that the surgery, I mean, because he's in subacute obstruction also, remember. So how many days would you want to take to optimize this patient? How quickly you'll be able to optimize? Arbitrary, I'm not talking exact.
Inpatient, for me, it's for me.
Yeah.
Yeah, so I think if the patient is a inpatient admitted, so 3 days to maximum, I think 1 week, we would see.
Sure.
If there's a fluid overload status is there or any other condition which could be treated. So first, I think we
Asha, in
usually-
any case, if you give a clearance for surgery or procedure, but do you expect it to be mild to moderate? I don't think so, right? It will be moderate to severe.
yeah, it will be always under high risk.
Okay, fine. Okay, Dr. Arnav, you can continue.
Yeah, just one question from my side. So, like Purish Parekh sir very rightly raised the question of life expectancy. So, we have also been using certain scales like the Lee index and
Yeah.
Lundberg index for the, the further life expectancy, non-oncological life expectancy. So, to the geriatricians on the panel, are you all routinely using these scales and do you use them in the patient counseling?
One wants to take the. I mean, I have used e-prognosis and everything. I mean, are the others using?
So in general practice, we are not using it. We are running a geriatric oncology clinic, and they are using, I think, parallelly. So they are using for them, but not for all patient in our OPD. So in the clinic, we do a comprehensive assessment, and in that we usually use it. Yes.
So I think it's something that we used to use in the geriatric clinic at Tata during my time there, and it adds a little bit of context, at least for us. So, if you have somebody who has a limited non-oncological lifespan, at least calculated, we would be able to counsel the patients better. We would be able to explain to them better how much we are likely to benefit from the intervention.
Yeah, absolutely.
So now coming to the CARG score for this patient. So, Dr. Kasturi, would you like to take us through the CARG scoring?
Yeah. So as we can see, the CARG score, the age is 78. So it's more than 72 years. Cancer, it is a higher risk as it is a GI cancer. And if we were to plan an ideal situation, we would have planned a FOLFOX 5FU based backbone regimen. However, we will discuss further as to why it will be a challenge for us because of the comorbidities in the sense of cardiotoxicity and CKD background. And again, hemoglobin is also, as we can see, is on the lower side. Creat clearance is also, as we have discussed, he has CKD stage 4. And however, he has no hearing impairment and there is a high fall risk, though no recent falls. So he needs a walker. So he has limited walking 1 block and he has activities of daily living limitations. And also he has health related limitations, as we can see. And definitely there's a polypharmacy. So this comes to a CARG score, which is suggesting a very high risk for chemotherapy related toxicity. So now this again, the same question that I was suggesting that at the very offset of this case is that it's going to be a real challenge for us to think of a backbone because 5FU as well as oxaliplatin is the backbone of a patient of CA colon. So now that's going to be a real big challenge for us to implement it in our treatment.
If you could just add for the panel, what issues would you expect with these two chemo medicines in this context?
Yeah. So 5FU is 5FU and it's capecitabine. So they have cardiotoxicity. Even though it depends upon the type of infusion. For example, an infusion 5FU and a capecitabine have a higher rate of cardiotoxicity to the tune of maybe around 10% or even higher for 5FU infusion. However, bolus, on the contrary, has a rather lesser cardiotoxicity range to a rate of around 1 to 3%. So if at all I have to choose among the 5FU based regimens, probably I might go ahead with a bolus 5FU based regimen with a Mayo Clinic based regimen where we predominantly used bolus 5-FU regimen. Again, coming to oxaliplatin is going to be a challenge for us because of the underlying CKD. So, in view of these two issues, also we know that capecitabine is excreted renally. So, capecitabine all in all will be very difficult to give in, which is actually very patient friendly in the sense it is a oral medication. So, many of the patients of this particular age group prefer to have a capecitabine after the risk of hand-foot syndrome explained. So, this is what I'm suggesting, that we might have to go with the abbreviated bolus 5-FU based regimen, not the conventional capecitabine or the oxaliplatin based backbone therapy is what I feel in this case.
Absolutely. We have a message from Purvish Parikh sir in the chat box. Sir
Okay.
has of course suggested as very rightly DPYD testing to see whether
Yes.
you should give any fluoropyrimidine at all. And sir has also considered S1 oxaliplatin in place of Folfox.
Yes.
I think, I mean, just an again open question to the oncologist, Dr. Kunal, Dr. Kasturi, that I feel that somehow capecitabine is more difficult to tolerate, though it is a more convenient oral dosage.
Yes. Yes, sir. Yes.
On
Yes.
patient 60 years and above, the toxicity seems to stretch out. So even if the renal function were normal, I would still be pretty apprehensive to give a capecitabine in this age group.
Yes.
Inputs from your side regarding that?
Yeah, I also feel the same. Yes, that is what the clinically. But when we counsel the patient, telling that it's a capecitabine is an oral medication, there is a predilection for patients to go ahead. But yes, definitely after 60 years, we do see rather more rates of incidence of other toxicities.
Dr. Kunal, any input from your side? Dr. Kunal? Okay, so I think sir is facing technical difficulties. We'll proceed with the next part of the discussion. So we have summarized the case. We have a locally advanced colon cancer with nodal disease. There is a subacute obstruction. Surgical decision is critical, and chemotherapy options are limited. So, are we even considering any curative intent here, or are we considering purely palliation? Dr. Dale, how many of these cases actually go up for surgery? So, if you're not able to operate, this is likely going to be palliative. How many of these cases actually go up for surgery in your experience?
Yeah, absolutely head on. Now, these patients usually don't come up for a definitive surgery. So it's usually a stoma, and then the optimization goes on, and then usually they don't make it because first of all, he is frail, there's malnutrition. Maybe about a few patients who come on table for a definitive resection. That's about it. It's not a major chunk.
Yeah,
Most of it, we have to just let go.
absolutely. So I don't think I'll just go to the next slide for this. So we don't have a note here on MSI testing. So medical oncologists on the panel, supposing this patient you have biopsied, you have a proof that this is an MSI high CA colon, will that change your management? Would you still consider that this is going to be difficult to treat or any other options?
Yes, sir. With the latest evidence that we have in view of the niche 2 trial. So even though we don't have a clear-cut survival benefit at this point, but yes, they did respond to the combination immunotherapy with a good pathological response rates. So maybe even though we'll explain the patient and after informed consent, maybe in this case, we might counsel for combination of immunotherapy for him.
Sure. Purvish Parikh sir, if you are, we could get your inputs on this. So supposing we had to deliver an immunotherapy in this kind of patient, a patient with subacute obstruction or a patient at this age group with sepsis and comorbidities, would you counsel them to proceed with immunotherapy or would you still prefer palliative care?
So I think immunotherapy is not without toxicity. And
Yes.
immunotherapy can have some serious toxicity even if it is not immediate.
Yes.
In my opinion, I would be very reluctant to consider this patient fit for immunotherapy. And my counseling would be just for palliative treatment.
Absolutely, sir. Thank you for that insight. So the points that we have discussed for this patient, surgical feasibility is going to be very difficult. high perioperative risk due to the cardiac failure and COPD, consider only a palliative colostomy initially. Try to optimize the patient. Systemic treatment, standard Folfox is contraindicated capecitabine, risky 5-fluorouracil monotherapy, or as Sir said, we can consider S1. Radiation therapy, probably no role in this setting. Supportive and palliative options, of course, is the symptom control, nutritional optimization. Maybe we can consider for TPN for a short time as indicated, and psychosocial support, early palliative care integration. So coming to the geriatrician driven interventions, Dr. Prem, if you want to take over.
Yeah. So starting with Nabil, so I think the biggest challenge here was the medical optimization. And I think it would have to be done irrespective of whether the person, what line of treatment the person would go for. So would that be a challenge, or would it be difficult to achieve any kind of medical optimization?
So in this patient with so much of comorbidities, it is really going to be a challenge, sir, because the patient has end-stage cardiac failure, COPD, that is recurrent admissions. Again, end-stage CKD, the patient is in stage 4 CKD. So this is going to be a real challenge in doing medical optimization.
Okay, and involving Nadeem here. Dr. Nadeem, functional intervention and improving functionality, having physiotherapy, maybe reducing fall risk. But do you think in this particular case, would it be very practical? Are we even able to, I mean, a person who's got heart failure with COPD, do you think the disease itself is going to drive the pre-morbid disease? I'm not even talking about the oncology part, is going to drive us finding it very difficult to provide this functional improvement interventions?
Yeah, I think as you told, have to go into detail of what is causing the functional limitations for these patients. So it may be the primary disease itself, maybe the dyspnea due to the severe anemia, heart failure. In a heart failure patient, HbF of 8 is very detrimental, and that itself can be the primary cause of functional limitation. So along with, we know that functional physio exercises can be done in a modest way, but still along with that there should be medical condition optimization, anemia correction, heart failure treatment, and COPD treatment. Along with that, the functional interventions has to be done. The medical therapy, medical optimization, along with functional interventions has to be done. But we can't wait for the medical interventions, and we can't wait for the patient to be stable to start the physiotherapy. That can be started in very early phase, which should be helpful and in a very modest way.
Okay, and Dr. Pramod, very crucial thing here will be nutrition, but we have been talking about it from the first part. So what would you feel? Do you feel it's going to be a long-term RT? Do you think TPN is a better option, or temporarily we give TPN, then RT, or maybe the person obviously will be able to come back to oral also, because RT, even for whatever time, comes with its complications.
Yes, sure. So I think one of the consideration was doing a colostomy for the patient to improve his
Exactly.
gut movement. And if the colostomy is placed, we could obviously see the patient's appetite. We can try to improve his appetite. If he's able to take orally, we'll assess oral intake. If it is not optimum, we could go for a RT. But if we are going for a palliative, I think RT has limited role, if you're not going for invasive therapy. So keeping the patient on RT is also not very beneficial, not improving his quality of life or his longevity, life expectancy. Then if the patient is in obstruction, subacute obstruction, and has other condition, this acute condition, we could go for a TPN as it was suggested. So these are the options, but we need to see the patient's condition, and if one important consideration would be if the patient could get a colostomy done. And then again, we need to take the patient's, the last point is very important. The patient's decision is if he's ready for colostomy. So this also need to be considered.
Okay. Purve sir, any points you want to add or you want to ask, of course? Okay. Any, Dr. Arnav, any final points from you and of course the medical oncologist?
So I think just to summarize all our discussion, it is very important to do a comprehensive assessment, the geriatric parameters and the comorbidities. And if those things are optimized within a reasonable time frame, it makes the further oncological treatments much easier. It also helps us to understand how much the patient's life is going to be affected by the cancer itself and how much is going to be affected by the comorbidities. So, both things go hand in hand. If anyone else would like to add anything from their side.
Dr. Kasturi, Dr. Dale, any
Dr. Arnav, you mentioned radiation has a very limited role. In a patient who is not able to come up for surgery and he's bleeding through the gut, we have limited options to stop the bleeding. Either we do an angioembolization, which could be dangerous. The second option that we think is of a palliative radiation, a hemostatic radiation.
Yes.
So that radiation can be an option sometimes. Very rarely we give it.
Absolutely. So, Dr. Dale, I mean, though I think most of our geriatric scales and the research is in terms of patients' fitness for chemotherapy. So, our CARG score and all, which we predominantly use. But having been a part of this panel and this discussion, would you feel that you would like these objective scoring systems to be developed for surgical risk as well? I mean, something like
Definitely we should
what do you
develop it,
usually use?
and it should be developed for the surgical aspect as well, because it's obviously taking up such a patient for even a stoma, which is hardly a half an hour to 1 hour procedure, is still considered risk, a very high risk. Such a frail patient, malnutrition, with hemoglobin low, his heart function not good. It's definitely, even a small procedure also is definitely a high risk situation. And a detailed discussion with the relatives, with the patient, should be done. Without that, there's no going ahead.
Absolutely.
Yeah, sure. Yeah, Purve sir, any comments, sir?
I think this second case was very interesting, and the discussion also reflected that. If you ask my personal opinion, I feel that the comorbidities are so significant that the non-cancer life expectancy is very low.
Yes.
And the second part is that many of the comorbidities, even after intervention, trying to reverse them, are not going to change. So their morbidity will continue. And as a result, this patient, I would counsel only for palliative and symptomatic care, and would give cancer-directed therapy only if forced to do so. I think of all the cases that have been presented so far, this has been a very, very interesting case because of the geriatric whole background and comorbidities that the patient has. So it was great that this case was presented. Thank you.
Thank you.
Thank you, sir.
I think if there are no more comments, then of course we can sort of close in. We are already taken them to 8 o'clock. Yeah.
Thank you very much, Prem. Thank you very much,
Thank you,
Arnav. Thank you, all the panelists.
Thank
This
you
was
so
a
much.
really superb discussion, and it brought out the finer nuances of how we treat oncology patients. So before I sign off, just a reminder that again next month we will have the fourth Geriatric Oncology Tumor Board, and all those who are interested are most welcome to join. Thank you very much, everybody.
Thank you. Thank you. Thank you.